All right, welcome to the lecture on toxicology. So the educational competencies are the same as they always are, is to apply a fundamental knowledge and provide basic and select advanced emergency care based on your assessment findings for an acutely ill patient, which means, yet again, that you can recognize when somebody is actually sick and needs definitive care, and you can reasonably determine what the causation of the medical problem is. Some of the things we'll be reviewing is recognition and management of carbon monoxide poisoning, some nerve agent poisonings, how and when to contact a poison control center, the anatomy, physiology, pathophysiology, assessment, management of inhaled poisons, ingested poisons, injected poisons, absorbed poisons, alcohol intoxication and withdrawals, opiate toxidromes. AEMTs can treat patients who have taken drugs or have a drug abuse problem, drugs being illicit or licit. And the illicit means non-legal and licit meaning legal. So even that is a little bit of a paradigm because we can have legal drugs that are illegally obtained. A couple of key definitions are poisons are toxic by nature. There are some drugs that have therapeutic effect if they're given in an appropriate dose and under the right circumstance. And an overdose is considered a toxicological emergency. Toxicology is the study of toxins or poisonous substances, and they can be either intentional or unintentional. Most can be found in nature and in the workplace. Many can occur from neglect or oversight. And again, they can be very much intentional in the means of nefarious acts such as biological warfare or the date rape drugs that can be given out. Poison control centers are available to everybody, be it EMS provider or the layperson. The National Poison Control Center hotline number is 1-800-222-1222. So a little about the pathophysiology or the routes of absorption. There are four main ways that toxins can enter into the body, and that is through ingestion, inhalation, injection, or absorption. Whereas ingestion is typically considered that you've eaten it. Inhalation is by anything that the respiratory tract is able to take in. Injection, meaning that it's broken the surface of the skin and made entry into the bloodstream that way. And absorption means that it can be readily passed through the skin and absorbed into the bloodstream that way. Most of the effects on many drugs or compounds are dictated by the excretion rate, which means how quickly the body is able to metabolize it and excrete it through either urine or feces, and in some cases it can be exhaled. For the most part, the most common sources of poisoning are medications, everyday medications that are found around the house. This could be something as what would be thought benign medications such as antacids. It could be Tylenol or ibuprofen. Or even simple household chemicals when mixed inappropriately or do not have the required ventilation to utilize that particular chemical. Some of these poisons can have an immediate or a delayed effect. And we'll use a couple of examples. If you mix, say, bleach and ammonia, you can actually release a chlorine gas, which would have an immediate effect on that person. The other issue would be perhaps, say, somebody takes a massive overdose of ibuprofen, which would be a considerable amount of pills to take, and those effects may not happen for several hours before we start to see the unintended consequences of that action. In regards to some of the simple treatments that are given for acute overdoses, there are some EMS systems that allow AEMTs to use activated charcoal. And the mechanism of action for activated charcoal is that it actually binds to the poison, allowing the body to dispose of it without it getting into the bloodstream. Activated charcoal is a pretty high carbon content. It's carbon by design, and because of the porous nature of that particular compound, it has a surface area that is extremely large in relation to the volume that it has. So what this effectively does is allows certain compounds and other things to attach to the carbon molecule and be absorbed or bound. It would be excreted from the body by either vomiting or through a bowel movement. So poisoning by ingestion. The most common sources of poisoning by ingestion would be medications around the home. And in medications around the home, we're talking about some of the over-the-counter medications, which could be as simple as something like an antacid pill. You can actually take too many of those particular tablets and cause an electrolyte imbalance and some other issues going on in the body, which would change your acid-base balance. Or perhaps say Tylenol, which is an over-the-counter medication that is highly toxic if taken in the incorrect amounts. Household chemicals, this would typically be something that was unintended ingestion, right? Perhaps a small child gets a hold of some kind of household cleaner and mistakes it for something, perhaps say like a Kool-Aid or other drink, and they unintentionally ingest it before having the yuck response, which would be to spit it out or vomit. Depending on the actual toxin, so the effects can either be immediate or delayed. And in the case of, say, something like Tylenol, it could take several hours for the damage to have been done because the body actually has to process the acetaminophen, thereby creating the damage to the liver because the liver is filtrating the acetaminophen out of the blood, which overloads it and actually causes the actual damage. In some of the household chemicals, perhaps say a cleaning substance, the effect may be almost immediate, right? We're talking about within a few minutes of ingestion if the person who swallowed that particular chemical did not immediately vomit it back up. Moving forward into inhalation, some of those common sources, again, are home medications. And they could be household chemical products. And in home medications, that could be a person non-prescribed, some kind of inhaled albuterol or something like that, where perhaps you have a small child that is playing with a meter dose inhaler and they repeatedly dose themselves because that's what they've kind of seen the intended patient use the meter dose inhaler for. This could become a toxic problem. Whereas it would cause harm if they got too much of the medication or an overdose. And then household chemicals, a good example of that would be mixing bleach with ammonia, which would release a chlorine gas, which would be inhaled immediately as well. Poison by inhalation can only occur if the poison is present in the atmosphere, which means that, again, that's that release of gas. And if you suspect something like that, that's one of those things where we're going to do our scene size up. And if we have multiple patients, we absolutely want to have a high index of suspicion that there is something in the atmosphere causing that particular injury. So it is absolutely the appropriate time to have the fire department respond to this initially because they have a self-contained breathing apparatus. So they can keep themselves from being exposed on the inhalation injury as well. As you guys remember, as we're continuing down the inhalation injuries, the lungs have a very high amount of vasculature, and as that toxin gets into the alveoli, it has a direct opportunity to get into the bloodstream, almost immediately. And the window for treatment is very narrow because of how quickly it's effectively gotten into the bloodstream and will then have the intended or unintended consequence. Again, you always want to make sure that your scene is safe, and anything that you find that is a clue to the actual poison or toxin should be taken with you in a safe manner so that the receiving facility can have a better handle of what it is that they're dealing with. If you can, that's something that you want to do an early heads up or early notification to the hospital that you suspect X substance is the poison that's affecting your patients so that they can get with the poison control center as well and get the appropriate treatments on board and ready to go as soon as you get there. If your patients are hypoxic, always, I mean, this goes without saying, if you have low oxygen saturation, they get a very high flow of oxygen treatment. And we'll talk a little bit more about that later. Now, moving towards the poisoning by injection, as this slide says, it's usually the result of drug abuse. The signs and symptoms can vary, and this depends on what the actual drug is, because some drugs are stimulants and some drugs are sedative in nature. And injected poisons are really impossible to dilute because you're going to get them into the bloodstream immediately. That's the entire reason for utilizing that style of drug, which is to have the onset almost instantaneously. If it's a drug that's injected and it's necrotic in nature or designed to cause tissue damage, if it's injected into a muscle, this can cause massive pain and tissue destruction almost immediately. And if it's in the bloodstream and it's designed to do that as well, it can do something very similar. A good example would be the patients who have poor vascular access and are using IV drugs, such as, say, heroin. They will do something that we kind of refer to in the field as skin popping, which is where they now are in such need of that particular drug, even though they do not have reliable means of vascular access. They will start actually doing sub-Q or IM injections of the drug, because they know that while it takes a lot longer for it to come on, they can kind of get it into the muscle. Uncleanliness of the way that they actually get this drug and administer it will actually cause massive tissue destruction in the injection sites. So you'll see patients that have large abscesses and other damage in multiple locations. Now, moving forward to the absorption route, we're looking at some of the more serious absorption poisons are pesticides. Corrosive substances that can damage the skin, the mucous membrane, or the eyes would be something like a acid, like a battery acid, sulfuric acids. Other substances can be absorbed and they have real high systemic effects, which means that they're going to affect many different body systems once they've actually made it into the bloodstream and get to their targeted organs. Being able to distinguish between contact burns and contact absorptions is probably a little paramount to your ability to treat. There can be what looks to be very similar kind of damage to the skin or inflammation if something has a contact absorption and it causes inflammation just on the actual section of skin, whereas a contact burn would come from something very acidic or very high alkalinity, and the two will have different effects, but the end result is that there's tissue necrosis. Continuing with the absorption is the signs and symptoms. So the history of the exposure is of significant importance. A very well thought out and detailed history of the present illness or injury is of paramount importance to your success in treatment. We really want to know, is this a liquid or a powder? Because we're going to try to remove that from the patient's skin in different ways. It could be heavy irrigation, but in the case of a powder, irrigating a dry powder may actually increase the rate of absorption. So you're going to kind of take that into perspective. Is there a burn associated with it because of the chemical reaction causing an exothermic effect? Or is there a very low pH balance or high pH balance to it, being the acid or alkaline effects to the skin? Is there any itching or irritation that's causing the patient to maybe strafe their skin with their fingernails, which is then now opening up the skin, allowing more damage to the tissue, or allowing even more of the poison or toxin to get into the bloodstream? Look at the skin. Is it discolored? Is it swelling? Is it hot to the touch because of the inflammation process? And then, do you smell an odor or a substance that's recognizable to you that would tell you what this particular compound is? We always want to make sure that we're not contaminating other patients. So if you're going to interact with these particular patients, you want to remove them from the substance or get the substance away from the patient. You want to get any and all contaminated clothing off of them. And then, if appropriate, you want to irrigate the area with water. And by water, we're talking copious amounts, not just a few cc's here or there. In this particular picture you're looking at, this patient has what appears to be bilateral eye injuries, and that could take several liters of water of flushing. If you look at most contact exposure plans on household chemicals, it will tell you that if you are exposed to that particular agent, that you should flush your eyes anywhere from 10 to 15 minutes with copious amounts of water. And so that generally means like a consistent flushing, not, well, put a little bit of water on it, wait for a minute, put a little water on it, wait for a minute. I mean, we're talking significant amounts of water to dilute that particular compound and remove it from the skin. There may be a high affinity for the compound to stay in contact with the skin, and water is not its normal solvent, which will not help remove it. So what do we mean when we say a toxidrome? A toxidrome is the syndrome-like symptoms of a poisonous agent, and so we'll kind of dive into that a little bit. But there are many drugs that will kind of mimic one another in a particular signs and symptoms, and so those drugs will fall into that toxidrome. Some of the major toxidromes are going to be stimulants, narcotics, sympathomimetics, sedatives and hypnotics, cholinergics, and then anticholinergics. And all of these will have their own toxidrome, which will kind of give you a little bit of a clue if you're unable to actually verify what the particular offending agent is, to at least what family or group it's going to fall under. This lecture would not be complete without the overview of a substance abuse, and the issue with this particular aspect of medicine is that it's highly challenging because it can come with a very significant psychiatric component to it, and there is a very high probability that we don't really understand what the prevalence of the problem is, and we're only barely able to keep up with the evolution of the substances that are constantly being changed or manipulated by chemists, and the cultural variations in what's actually considered a substance abuse. To put this in perspective, you may have a tradition in your family where having one or two drinks with dinner or after dinner is very normal to everybody in the family. And then there may be some that they consider 6 or 7 drinks as a regular basis of interaction during dinner or at night is very normal to them. So this is all a matter of perspective. If you're thinking about it, it's very culturally different for different people to do different things. And what one society may define as unacceptable, another group in that same kind of societal platform may think that it's completely normal. And so the trouble in this is that actually trying to get everybody to kind of agree what's an abnormal behavior or an abnormal amount of a substance to be ingested on a regular basis could be completely different. When we're talking about substance abuse terms, drug abuse, habituation, physical dependence, psychological dependence, tolerance, withdrawal syndrome, drug addiction, antagonist, potentiation, and synergism. So we're going to talk about most of these as we can. Drug abuse is clinically defined as anything that interferes with normal everyday life or tasks, because the drug is now becoming such an important part of that person's daily routine. Habituation is something very easily considered. It's just the habit forming of the drug. So you could think of perhaps tobacco use, where somebody becomes more and more chronically habituated to want to actually utilize that particular drug, even if they don't need it. Physical dependence is when the body develops this dependence on the drug to kind of create the intended effect, which almost always comes with a psychological dependence. And that's where the brain is rewarding the body with dopamine as the trigger for wanting more of that drug. Tolerance is pretty easy to understand. When we're talking about tolerance, that's the body's receptor sites becoming kind of immune to the same amount of drug. It's not giving the same effect. And so the patient or the person who's utilizing that substance has to up the amount to get the same dopamine response from it. Withdrawals are when the body literally is having an issue with the removal of the drug, and it will start to actually manifest in physical symptoms that will help to kind of create that need for the drug again. Some withdrawals can actually be life-threatening, such as alcohol withdrawals, whereas a lot of the opiate withdrawals are very flu-like symptoms, which really are not a life-threatening kind of situation, but they will create enough pain and discomfort in that patient that even if they're deliberately trying to withdraw from the drug, it's going to create that situation where they're going to want to take it to remove the symptoms. Drug addiction is literally just as simple as it sounds. You have developed a habit and either a physical dependence or a psychological dependence on the particular compound. And again, it's interfering with your day-to-day activities or the ability to be happy without the particular compound. When we use the word antagonist, that means that it is counteractive to that particular drug. And so what we should talk about in that is that naloxone or Narcan is an antagonist to opioids. The two will fight for the same receptor space, and the antagonist will kind of block or blunt those effects of the particular drug that wants to share the same receptor site. Potentiation is, I guess, an action potential, which means that a particular drug or compound will allow another drug to work. And synergy means that these two compounds will actually work together at a much greater effect than one or the other. And a good example of that would be if I had a drug that produced, we'll say, on a scale of 1 to 10 at level 2, and then another drug that's also produced a level 2. Combining them, you would think that they would either be a 2 or a 4 just by additive numbers or averaging. But in reality, these two drugs will potentiate and then create the synergy of, say, a level 8 experience on this particular compound. We're going to beat this dead horse again. Scene safety. Always, 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 when you're responding to anything that sounds like it's an ingestion or poisoning or an overdose, is to have a high index of suspicion that you could be exposed to this particular compound or chemical. You always want to make sure that you understand how many patients are involved, because when we have multiple patients, we have to consider that this is an atmospheric or environmental problem. And then, do you have enough resources? Don't ever get lulled into the idea that you can kind of deal with more than 1 or 2 patients at a time, because traditionally, if you have what we would consider a red patient, they're going to have all hands on deck trying to stabilize them. So if you have multiple patients, you're going to need additional resources. And then try to consider whether or not there's some kind of spinal immobilization that's required. Right? Did this particular situation create a traumatic event? So did a car accident result, or is there something else where there's some kind of trauma? Make sure that you're wearing your appropriate PPE. For the most case, the nitrile gloves are an impervious barrier to most compounds. I would say that I would be reasonably safe to interact with most people, regardless of what compound's on them, unless it's very corrosive or wants to actually degrade the PPE at that point. So as we're looking at this picture, I have no idea what they're trying to make there. I would suspect, based on the funnels and the beakers, that this is some kind of illicit drug lab, and I would be very highly suspicious of what's going on and remove myself from the situation. As you can see in the background, there's a lot of propane canisters, and looking at the beakers and the kind of like homemade chemistry that's going on, this might be a clandestine meth lab. And so when you see that kind of stuff, that means that it's time to remove yourself from the situation, because most of these compounds are volatile and can cause serious harm. Look for anything that's going to give you a clue. That would be medication packages like the Sudafed or something like that, which should also be a tip that somebody's trying to kind of create methamphetamines. Or look for alcoholic beverage canners or containers, syringes or other paraphernalia. And if there's an unpleasant or odd odor that you know shouldn't be in the atmosphere. Those are all, again, things to tell you that it's time to back away and get somebody that's probably a little bit more prepared to be in there. We're always using our primary survey to kind of figure out what's going on. Now, this begins with your general impression, sick or not sick. And if you guys have been in lab with me, you understand that we teach you guys to always make that general impression, is this patient sick or not sick? And then we go through our algorithm of body systems to figure out, are we actually correct? Are they sick or not sick? And this generally takes you into your secondary before you can actually determine that you are correct. So you want to identify any life threats, and that would be altermentation. Do they have any bleeds or things sticking out of them that they shouldn't? And then, are they breathing? So these are big, broad ideas, and then we'll go into the secondary stuff. Obviously, if your patient doesn't have a patent airway or they're not breathing adequately, you're going to have to do that for them. We do want to know that if they've ingested a poison, is there any kind of caustic substance, because that may keep you from actually utilizing a supraglottic airway, and you're going to have to be very diligent with your BVM and your ability to protect their airway for aspiration. Never withhold oxygen when it's indicated. The ultimate goal is between 90 and 94% O2 sat. We don't have to have that 100%, although in the case of an inhaled gas such as carbon monoxide, because of the affinity of carbon monoxide to sit on the red blood cell over the oxygen, that is a high flow oxygen. We need the partial pressure of oxygen to help push the carbon monoxide off of the red blood cell. So in that particular case, you would be fooled just by a SpO2, because it will say 100%. That patient is going to consistently and persistently get high flow oxygen, because we're really trying to coerce the body to release the carbon monoxide from the red blood cells. We're still in that primary assessment, but now we're looking for that circulatory status. If a patient has some kind of mentation and we know that they're breathing, they obviously have a pulse of some sort, but we still want to assess the skin. Are they pale, cool, and clammy? Are they shocky? Is there a bleed? And if there was a significant bleed, we should have been on that already. And then we want to make sure that we're going through our algorithm. So again, for trauma, it's usually CAB, and for medical, it's going to be ABC. If you delay on scene, that's probably not doing anything for your patient, because in the case of toxins, time is your enemy. We need to make sure that we have whatever neutralizing agent we can into the bloodstream, or something to bind with that toxin, or some way to remove that toxin from the patient as early as possible before enough of that particular compound does the damage that it's going to do inside the body. If at all possible, a rapid decontamination of your patient is the most appropriate thing before you get them into the back of the rig, because you want to lessen the likelihood of you being exposed to that agent while you're performing your treatment.